physiology, because a lot of these disorders of the hypothalamus and pituitary do go hand in hand, and they have problems in terms of development on the gland. So I've already said that pituitary basically develops as a dual origin. There is a adenohypophysis, which basically means a gland, neurohypophysis, which basically means a nerve. So there is a two different structure. One is mesodermal, you can say, the other would be ectodermal in that regard. So you've got neurohypophysis and adenohypophysis. So you've got the neuroectoderm and you have got the pharynx. So one of these has to go up, the other has to come down. So this is something which is important on that regard. So you've got the up growth of the pharyngeal pouch, and you've got the down growth of the neuroectoderm. From there, you develop the rat case pouch, which is basically coming from the pharynx, around 3 to 5 weeks of gestation, and then it is going to go up, and the neural aspect is going to come down. They're going to meet together, and you will have going to get a cyst which is going to develop in between, which is known as the rat case cyst. And we all know that if there is a persistent rat case cyst, that is going to cause a lot of problems, because it may inflate, it may cause pressure effect, you will have a hypogonadism, you may also have precocious puberty because of the stimulatory effect from that perspective. So by 12 weeks, you've got the complete pituitary development which happens. The process of pituitary development is genetically regulated, and this involves a number of transcription factors which act in an orchestrated fashion. Transcription factor. So they are regulating transcription. Transcription means what? Conversion of DNA to RNA. So your RNA production is stimulating. Now everybody has got same genes. Every cell has got same gene. But the expression of the cell depends upon the time, the place, and the requirement. So which gene should go up now and which should go down will is regulated by the gene transcription. So the most important regulator of that are these transcription factors, which are essential for the pituitary development. And when I say orchestrated growth, you need to understand that orchestra, some people go up, others go down, and then they will go down, others will go up. So they will be like a rhythmic fashion. So it's like a music, you can say, as far as pituitary development is concerned. So the early embryogenesis, this is very, very early stage. We are not even talking about pituitary, we are talking about the craniofacial development. Then you have got the cellular differentiation. Your cells are developed, they are differentiating, and then individual cells are becoming into the mature cells. So it's good to classify this into 3 phases. However, this is a continuum. So we cannot say basically that, okay, this is completely distinct. But if you remember this, you can think of, like we say, BC and CE, before Christ and after Christ. What will be the landmark event as far as pituitary development is concerned? Which gene? Yeah. Before that and after that? Prop 1. So prop 1 is the major one. Before that, you're talking about early embryogenesis, craniofacial development. After that, you really have the pituitary which is starting. And what prop 1 does is not just activate the further genes, it suppresses the previous one as well, because you don't want continuous growth of all those factors. So earlier embryogenesis basically starts off with some of the canonical factors, the common factor which happen in bone, which happen in ovaries, everywhere. WNT5, FGF8, these are well known. BMP, bone morphogenic proteins, their name is actually derived from different parts. So these are part of that, and hedgehog, sonic hedgehog, they all play a part as far as the overall development. What is a hedgehog? Hedgehog is what? Animal who has got that special spike. Syahi is known as Syahi in our region. So these are individuals who have got a lot of these spikes. So based upon the sonic hedgehog, based upon from where the gene was derived, that's how it's named. So you need to understand how they have come from also in that regards. So HESEX, as you said, okay, you can say the first initiator, or you can say a true pituitary gene may be a HESEX1, but this is a very early stage. Now this HESEX1 along with SOX3 plays an important role in the initial craniofacial development. So from here, you've got the rat case pouch, which has come in. You've got the descent of the neurohypophysis. Therein come in the LHX 3 and 4. So when you have a problem in the HESX1, you not only have a problem in terms of pituitary development, you have a problem in the eye development, the ear development, the cleft lip, the cleft palate. So many things may be affected. The septo-optic dysplasia will happen. So optic nerve may be affected. So a lot of things will happen. As you move towards the right, gradually you are becoming more specific. So LHX3, LHX4, basically they will have abnormality in the spine. So rigid cervical spine with hypopit, that's how they will come. Subsequent to that, the watershed movement is prop1. So by the time prop1 has come in, you have got enough development. So to say, okay, this looks like pituitary now. From here, prop1 does two things. It stops all these processes. So if you do not stop this HESX1 or SOX3, continued growth may cause a lot of problems. So prop1 is inhibiting pituitary growth on one hand, and it is stimulating a more regulatory growth from the other hand along with GATA2. So if you have a prop1 defect, what will happen to the pituitary size? It may So you may have an enlarged pituitary because these useless agents who are not useful subsequently, they will keep on proliferating, but they are not going to make any helpful. So the pituitary size may be variable in prop1. It may be small, normal, increased, and it may regress also. So this is all part of the prop1 problem which happens from that perspective. So prop1 and GATA2 is going to inhibit all these, and it is going to then take help of the SF1, which is NR5A1, and the other, the second, the DAX1, NROB1. These two will play an important role now from that perspective. Now, second big agent, or you can say the right-hand man of prop1 is POW1, F1, also known as PIT1 earlier. So prop1 and POW1, F1 are going to regulate the individual cell types to grow. The POW1F1 goes to PITX1, 2, 3 to regulate the growth hormone, prolactin, and gonadotropin, and the thyroid in that perspective using the TSH beta as well. So if you have POW1F1 defect, what is the classical presentation of POW1F1? So they are the worst cretin, quote unquote. The first case report was a most severe form of cretinism, which was because of this gene defect. Prolactin levels are low and pituitary size is small. So they will have hypoplastic pituitary. This is the classical example from that regards. Now there are certain other genes which play a role, including the TPIT, the LIF, the NeuroD1, which regulate a very, very important aspect as far as the adrenal development is concerned. So they regulate the POMC, and POMC we know is pro-opiomelanocortin. It is going to regulate MSH. It is going to regulate endorphin. It is going to regulate your cortisol ACTH level. So if you have a POMC defect or a pro-convertase defects, what will be the clinical manifestation? Yeah. So you will have hairs which will be depigmented. Yes. Obesity. And central hypocortisolism will be the other scenario. So they are regulating the ACTH. Prop1 is also regulating ACTH in additional to GH, prolactin, TSH, and variable gonadotropin deficiency may happen. Now, GATA2 along with FOXL2 regulates the alpha subunit. So we know that every of these glycoprotein hormones have got the alpha subunit and the beta subunit. The TSH beta is a separate gene. And when we talk about central hypothyroidism, remember we talk about TSH beta, TRH defect, IGS-F1 defects. These are become important, but alpha subunit is also important. And alpha subunit is common not only to TSH, but also to LH, FSH, and other hormones as well. Now, FOXL2 regulates the LH-FSH beta gene, and therein play an important role of SF1 and DAX1. So NR5A1 and NROB1 play an important role in that regards. So what are the manifestations of DAX1 defects? So that's a very interesting scenario. You may actually have a large penile size to begin with because of these inhibitory effects, but ultimately they will have a hypogonadotropic hypogonadism. What about DSD? DAX1 is what? It's an anti-testosterone hormone. So overexpression of DAX1 can cause a XY DSD. It's a known cause of XY female. So it's like a complete reversal. But what we're talking here is deficiency. So that is overexpression. So don't get confused that they will have a similar thing. What is the primary role of DAX1? Biochemical role. And what is the role of NRI51 or SF1?
NRI51 helps to enter the cholesterol into the mitochondria.
Which cholesterol? So it transfers the HDL cholesterol. The process is inhibited via NROB1 on DAX1. So DAX1 is a antagonist. It's a matter antimatter sort of a thing, positron, electron, that sort of a thing. So it's going to oppose that. So DAX1 and SF1 are in a competitive fight, which is there from that perspective. So gonadotropin is regulated by that. So SF1, DAX1, they all have a gonadotropin effect on that regards, as we discussed. Individual systems, how do they develop and how do they mature? Which one do you think will be the first to mature out of these growth hormone, thyroid, prolactins, CRF, and GnRH? Which one will be the first to develop and which one will be the last to develop? So you want cortisol is the most important? What is the role of cortisol in the fetus? So there is a role of cortisol in the fetus, which is so in a female fetus, if they do not have cortisol at 8 weeks, you will have a lot of androgens which will come in and that will cause virilization. So that is something, there is a priority which is there from that regards. But most of them develop by 8 to 12 weeks. I said pituitary itself takes up to 8 to 12 weeks roughly. So growth hormone starts happening by around 8 weeks. But then the growth hormone levels are not huge in the fetus. ACTH very important. If you do not have a 8 week, that will be a problem in that perspective. 8 to 12 weeks, cortisol comes in. So ACTH is there, but cortisol is not there. You will have a problem. Why don't girls with MPHD who do not develop cortisol develop these DSTs? Yeah, so we said cortisol is very important to inhibit that, and that's why they will develop, otherwise they will develop DST. So it's there in CAH also. So why do girls with congenital adrenal hyperplasia virilize while those with a central cortisol deficiency not? Because your ACTH is not going up. Simple thing. Because there your problem is that ACTH goes up and it is diverting all your steroidogenic pathways to the backdoor pathway or the aldosterone pathway. Here your ACTH is also low, so this cortisol is not going to make a role at all in that perspective. Now TSH starts coming at 12 weeks. It's not starting early. So what does it mean? That if you have a athyrotic fetus and the mother is not giving enough thyroid, you will land up in a trouble. The other thing is that if you have athyrotic fetus and the mother is having good amount of thyroid, you will not have a problem in intellectual development. This also tells you the onset of thyrotoxicosis in the fetus. What is the typical age when your fetus will develop thyrotoxicosis? So when should you start screening for a mother has got Graves' disease? When should you start screening for a fetal thyrotoxicosis? 30 weeks is too late, but not before 18, 20 weeks, because 12 weeks is when this axis is maturing. So the fetal thyrotoxicosis is through the fetus, not through the mother. So then in that case, you just need to monitor maybe after 20 to 22 weeks, then you start getting concern. LH starts at 12 weeks, which is important to understand. And if you have got no LH, how do they produce testosterone? If the fetus does not have LH, how does the male fetus produce testosterone? Yes, so this is very important. Because LH and HCG are structurally very, very similar. Placental HCG takes the role of LH in the 8 to 12 weeks to produce testosterone. Otherwise, everybody with hypogonadotropic hypogonadism will have a DHT. So that's a rule that in general, hypogonadotropic hypogonadism does not cause a XY DHT. However, there are some exceptions which people have found out that there may be some hypospadia which are there, but then that is a different ball game altogether. Now, thyroxine actually starts developing by 20 weeks. So you will have no fetal thyrotoxicosis by 20 weeks. That's something which is clear. Testo comes at 8 weeks because of the HCG effect. Estrogen, when we talk about ovary versus testis, what are the difference between fetal ovary and fetal testis?
The fetal ovaries are quiescent, they do not.
Fetal ovaries are quiescent. Which part? So the steroidogenic part is quiescent, but their oocytes are they are multiplying, gaining in number. The testis is the opposite. The spermatid, spermatogonia, all those are sleeping. But the Leydig cells are working a lot. So there's a difference between the female, male development in the fetal period. Now, prolactin comes in by 24 weeks. Of course, it's not going to do much role in that perspective, and that becomes important. So now, once you have this postnatal changes, herein lies the importance of pituitary. If somebody has got no pituitary, they will be born normally. They have no problem. Maybe they have micropenis or something like that, but they will not die in the uterus. But postnatally, pituitary is absolutely important, and you need to fight three major challenges. What are the three major challenges of a newborn?
The temperature regulation is one.
Temperature number one, cold temperature number two,
That is supplied.
glucose, and so that's temperature. Calcium, sodium, so everything. So calcium is PTH. Glucose is
Other
epinephrine, cortisol, glucagon, all those things are there. But then again, there will be a role of pituitary which is going to come. Temperature, thyroid, that is also going to come from the pituitary. Sodium, again, all these aldosterone, you will have ANF, you will have AVP. So pituitary plays a very, very important role in postnatal adaptation. So as soon as the maternal process is stopped, you will see changes which is going to happen. So your growth hormone level will rise at birth. Why does the growth hormone level rise at birth? So fetus is a relatively growth hormone deficient state. You don't need growth hormone for the fetus. Immediately after birth, however, growth hormone increases. This is mainly because of lack of inhibitory substance. But what does role this growth hormone will play? So yes, so the major role is not growth. We'd say that, okay, 6 months, maybe some people say 2 years also growth hormone doesn't play a role in growth, but I would say 6 months to 1 year. But this role is mainly for glucose metabolism. Which aspects of glucose metabolism is most critically regulated by growth hormone? Yes, so lipolysis will be there. So you will use your fat stores which the baby has stored at that point of time. Then the TSH will go up. Why does TSH go up?
TSH goes in the fetus, the TSH levels are low at the time of birth, and suddenly due to the requirement of
so TRH goes up and TSH goes up. See the difference. Growth hormone is not going up because of GHRH. It's going up because your inhibition is not there, which means it's a side kick. But for TSH, you have got a special hormone, thyrotropin releasing hormone, which is going up a lot. So that is why this TRH is regulating that. So that's a positive thing. And of course, thermogenesis is a major role as far as TSH is concerned. Prolactin goes up. Why does prolactin go up? Lack of inhibitory substance. So prolactin is just a sidekick. It's not going to do anything. So it just goes up because there's nothing, dopamine is less. So that's why your prolactin goes up. What about ACTH?
It will go up, but not in the subsequent. It will take time, like 17 days to.
So ACTH will go up in 7 to 10 days. So why do we do 17 OHP after 3 days? So this will surge earlier. So this is the time your surge will. So by the time 7 to 10 days, the surge will go. So the ACTH is important for glucose, for getting cortisol in and everything. So that's why don't do 17 OHP in the initial phase. It will be falsely high from that regards. What about puberty? And we discussed about pubertal regulation. What happens postnatally? So what is at birth? First of all, start from there. What is your testosterone level in a boy at birth? At birth, it's high and then it will crash down. Then 1 to 2 weeks already. 7 days typically it starts growing up, which is the mini puberty, which is basically because of lack of inhibition. And we discussed a very good paper last time that there is a mechanism of inhibition which is developing in mini puberty. So mini puberty is closed by the development of a feedback inhibition. What about girls? Estrogen levels are not very high at birth. The first antral follicle may develop during the last part of gestation. But yes, you will have a fall and then again a surge. Estrogen will go up, which is the mini puberty typically again, which is there from that perspective. So a lot of changes happen during the birth. In a nutshell, you have got more growth hormone, more thyroxine, more prolactin, more cortisol, more amount of testosterone. So everything goes up.